And welcome to the 77th Presidential Advisory Council on HIV/AIDS, also known as PACHA, Full Council of PACHA. And on behalf of myself and my other co-chair, Dr. John Weisman, we thank you for joining us here in Phoenix, Arizona today. Whether in person or virtually, the work that we do here is heavily guided by your experience, voice, and input. And John will share more about how to do that in his opening remarks momentarily. What we've been up to since our last meeting, well, we've been planning to be here. We are excited. This council and community feedback that we've received really directed us to come and hear with intentional focus on the They really helped to support pulling this meeting together. I also have to thank two of our federal partners and colleagues, Rick Haverkate with the Office of Clinical and Preventative Services within Indian Health Service, and Dr. Michelle Sandoval Rosario, PACE Region 9 Director and Senior Lead for America's HIV Epidemic Analysis Dashboard. Both of them really worked with PACHA to ensure that our time spent here in Phoenix was enlightening and insightful. So give a round of applause for them as well. And we're going to hear a lot more from Rick and Laura specifically later on this morning. But I also want to express my thanks and gratitude for the hospitality and welcome spirit. We really appreciated our visits on yesterday. So to the leadership and the staff at the Southwest Center, the Phoenix Indian Medical Center, and Native Health. I mean, your authenticity and approaches in the work that you do and that you shared with us was really so evident. And I'm very eager to learn more as we go through some of our panel conversations today, and how PACHA can assist, how PACHA can help influence, how to expand and sustain a lot of the great work and efforts that you're currently doing. And I'd be remiss if I didn't mention PACHA hasn't necessarily focused on the HIV epidemic specifically in Native populations in many years. So I'm really, really grateful that we are renewing and we get an opportunity to renew that commitment right now. I also think it's important to really talk about some of the challenges in our work ahead. Across the country, our nation is being besieged by attacks on LGBTQ individuals and programs, from drag queen bans and anti-gender affirming care legislation across many states. I think the small gains that we've been able to make in recent years to ensure that we had LGBTQ equality and access are now being met with significant hostility and backlash. And I believe that the rise in LGBTQ anti-rhetoric really correlates with increased violence, unfortunately, against these communities. So we do have much work to do to ensure that every person is treated with equal value, equal dignity, and that access to quality health care as a basic human right is provided to all. So I believe it is up to us that we have obligations to help dismantle systems that perpetuate social and racial injustice. You'll hear a bit more today about PACHA's intended work to address HIV stigma and other issues of social injustice. On the federal front, we are certainly excited that on June 8th, the Department of Health and Human Services released the first ever STI federal implementation plan, which details roles and responsibilities that our federal colleagues and agencies will take to implement that strategic plan running from 2021 through 2025. This implementation plan highlights over 200 actions that federal stakeholders will take to achieve the strategic plan goals of reducing adverse outcomes of STIs, accelerating STI research, technology, innovation. Part of what we know is we are fresh off the heels of budget negotiations on the debt ceiling, where funding, unfortunately, was rescinded that supported the DIS intervention specialists, the DIS workforce supplemental grant awards, resulting in a net loss across the country of about 3,000 supported jobs. And really, unfortunately, at a time where many jurisdictions are seeing elevated, if not outbreak levels of syphilis infections, especially among women and babies. As PACHA, we recognize that we must continue to call on our federal partners and colleagues to rapidly intervene in these current record high levels of STIs and to invest significant funding and resources, even for the CDC Division of STD Prevention, who already carries the burden. And HHS Office of Infectious Disease Policy really need support to fully implement that plan. Sort of lastly in my remarks, I want to talk to the membership about PACHA's leadership transition. I want to remind PACHA members that we are in a summer of transition. After this 77th meeting, Dr. John Weisman and Carl Schmid's terms will expire. We will lose another 6 powerhouse members at the conclusion of the upcoming 78th meeting. And we are waiting, however, on approval package that will hopefully onboard additional members. So I wanted you all to be aware that we are anxiously awaiting approval of those additional members. And as PACHA leaders, John and I have been working very closely with Kay and the team at the Office of Infectious Disease Policy to make the transition and new leadership appointments smooth and hopefully seamless. So we will continue to keep you all posted over the next few months, so stay tuned. And with that said, I want to take a moment of personal privilege to recognize the 2 giants that I mentioned that will be ending their service at the conclusion of this meeting, John and Carl. I have a small token of admiration for the immeasurable amount of work and guidance that the 2 of you have provided to us, this council, but also to communities across the country impacted by HIV, and also to our federal partners and colleagues. I hope it goes without saying how much you will be dearly missed and having you around this table. We know we will have you in the room, but we will miss your space and face and comments around the table. So I wanted to share a few appropriate and descriptive gifts that I think speak completely to your personality and to your soul. You can dig through the bag as I speak. I want the rest of the table to know what I've included in their bags are a couple of Smarties, because guess what? Their brilliant minds and words of wisdom cannot be overstated. And they're nuggets of gold that help to center practicality and effectiveness on the response in public health epidemics. You also in your bag have a payday. Because your years of volunteer service and around-the-clock effort, I wanted to finally provide you with your well-deserved payday. Also in your bag is a Mr. Goodbar. Well, you know, because why not? Also included are some lifesavers. Sometimes in public service, we may not always see or recognize the impact of our work. I added lifesavers to remind you both of your everlasting systems changes that have helped to create life-saving opportunities for the masses of the people in this country. And then last but not least, I've included Hershey's hugs and kisses. So not fully saying goodbye, but I will see you later for now. And I leave you with those hugs and kisses. Thank you, John. Thank you, Carl.
Wait. So the only thing I could say is how sweet.
Thank you, PACHA members, for indulging me, and I will now turn the microphone over to my co-chair, John.
Great. Marlene, thanks so much. That's very kind of you. The whole team here at PACHA is quite special, including all the staff and supports and our members on the council. So it is what we all do together. And it's an honor and a privilege for us to be able to have these leadership roles. And Carl and I, started the reconstituted PACHA under the Trump administration, where the ending the epidemic sort of was born in terms of that idea. And I think our role and what we play in advising administrations and our ability to continue to do that in the Biden administration is something that I don't take lightly. And it takes all of the whole of governments and communities and society to really tackle this. So we're all in this is the basic message. So I'm John Weisman, pleasure to be the co-chair of the PACHA for this last meeting. And I use he, him pronouns. With that, I too just want to say that, number one, I'm thrilled that we're here in Arizona being able to lift up the good work and the ongoing needs of our tribal partners and American Indians, Alaska Natives throughout the country. And to really put a focus on that. Today's agenda will focus a great deal on this. It's the primary agenda for today. We'll be talking about sovereignty, issues in the American Indian, Alaska Native communities around HIV, how they're being addressed. As PACHA, we will be listening carefully for the systems and policy kind of issues that we need to raise up and speak to as well in our advisory role. We'll hear about HIV issues in our American Indian, Alaska Native youth. And we will be doing our famous PACHA-to-the-People, where we will be listening directly from folks here in the community, and appreciate that. Prior to that, we will be doing a few other things. We will be looking at a statement around zero HIV stigma that we want to discuss and approve with this group. We'll be hearing from Harold Phillips, the Office of National AIDS Policy, the director of that at the White House today as well. Tomorrow, then, we will focus a great deal of our time learning more about sort of Arizona as a large state as well, and the efforts there to address the epidemic, both in the community and what state and local governments are doing as well. So we'll spend a great deal of time there talking about and listening to those issues. We'll have committee report outs as well from PACHA, and then have a chance to talk and reflect on the meeting and what things have come out of this, what we're taking away, and what work we want to do in the meantime. As we go into today's conversations, I just want to give everybody permission around this table that it's important that we have open and honest discussions, and that we raise issues that are important to all of us. And sometimes we hold ourselves back. Maybe we're not certain about our language or our comfort level with our full knowledge. This is a place where we want to say it's okay wherever you are. We want your engagement on that, and there's grace for any sort of mistakes we might make along the way. We'll be hearing more about these issues today, but two things that I just wanted to put out on the table as we move into this. One is that our tribes in the United States are sovereign nations. That is, they have their own governments, they have their own policies, they are separate, and just like other countries, they are countries, each of them, and we need to respect that sovereignty, that independence, and understand how we all work together. We have treaties. The U.S. government has treaties with tribes that really set out our duties and responsibilities as a U.S. government. And those are particular to the tribes that those are negotiated with. And it's important that when we're working with certainly individual tribes, but as a whole, that we understand that, appreciate that, and learn what that means for our work. And as PACHA, what that means to the recommendations that we bring forward. The other thing that I think is also helpful to understand, I know we're going to hear more about this, so I'm basically just sort of previewing some of the pieces is that tribes are distinct political entities. They are sovereign nations. And while when we look at race and ethnicity, we include American Indians, Alaskan Natives, but in truth, they're political entities. And there's an important distinction that when we do that work, that we understand that and understand the implications of that. And how people like to be identified. So we'll hear a lot more about that as we go forward. And before we move into our blessing, I want to gratefully acknowledge the Native peoples of whose ancestral homelands we gather, including the Tohono, I gotta look at my right pronunciation here. Tohono O'odham, close enough. We've practiced this much times. And of course, when the spotlight's on in the Pasqua Yaqui, as well as the many diverse and vibrant Native communities who make their home here today. So we want to acknowledge the ancestral lands and the importance of that and the appreciation for our being on those lands. And with that, I think I'm going to turn it back to Marlene.
Sure. And I will lead and facilitate most of our conversations throughout the day. And John and Carl, I think it's only befitting they will help lead our conversations on tomorrow as their last hoorah together, as I have to step out and leave the meeting early after today. But I really hope that we invite, moving on our agenda, a blessing of this convening and really the learning from what we will hear. So next up, we have Barnaby Lewis, Tribal Historic Preservation Officer for the Gila River Indian Community since February of 2009. The Tribal Historic Preservation Office consults with federal and state agencies regarding matters of religious and culturally significant interests of the Gila River Indian community. So please help me welcome Barnaby Lewis for his blessing.
Right. Hopefully everybody can hear me. Yeah. Barnaby Lewis to the Jivat Amjit. Sapita, Jajivia, Eden, Tashkam, Hoig, the Kasham, Tashki, that the Bab either with him that no much Bataga either Jivat, Toitaik, the Nat of them, Evum, the Apache, the Humapik. Good morning. My name is Barnaby Lewis. I'm from the village of Blackwater, located on the east end of Gila River Indian community. Pleased to be here today to offer prayers on your behalf to the Creator to bless this gathering, and that everybody be given that what we call the bright hearts, shining hearts, meaning that respect will originate from that heart, and that cooperation and understanding, will be shared among everyone here that has come together for these discussions that's of everybody's interests and concern. Here in Arizona, we are called the PEMA by the federal government. Our community, Gila River Indian Community, was established by executive order in 1859, originally 64,000 acres, equaling out to 100 square miles. Today, it's comprised of 372,000 acres, equaling out to 550 square miles. Akimuratam. We say river people, Akimuratam people, although the river that runs through the community has been dry for at least 100 years because of ranchers and farmers to the east diverting the water many years ago and dried up the river. But we still call it a river. We're still Akimuratam, and we're still the Gila River Indian community. Archaeologists call our ancestors Hohokam. We say we are Hohogam. Hohogam are our ancestors. This land that we stand on today, the whole southern half of Arizona, if you know where Prescott is here in Arizona, all the way across the state, going south to the international border, our ancestors, Puhugam, lived and walked on this earth. But archaeologists say Hohokam lived and walked on this earth from 300 years before Christ using the Christian calendar, and then disappeared around 1450 after the death of Christ. But in accordance with our story of creation, we maintain and assert that our existence, our ancestry here in southern Arizona, began way before 300 years BC. Our ancestry began 18,000 years before Christ. And it doesn't end at 1450. It continues on through today, tomorrow, and into the future. We still have this duty and responsibility to maintain and continue the traditions, cultural teachings that we've learned and have been passed down through us through the generations, such as our language, our songs, our dances, our ceremonies, our stories of creation, and most of all, our traditional religious practices. Because sadly to say, here in 2023, the non-Indian world does not believe that we still speak our language or sing our songs. That's because they've never seen us, they've never heard us, they've never visited us. Today in Arizona, there are 22 tribes, federally recognized tribes. And as Akimaratam, there's 3 other O'odham communities here in southern Arizona: Salt River Pima Maricopa Indian community, the Tohono O'odham Nation, and the Akshan Indian community. We have what they call a group shared identity. We speak the same language, just variation in dialect, our songs, our dances, our stories of creation, and our traditional religious practices. Very, very similar. May not be exact, but very similar. So we consider ourselves the O'odham family of southern Arizona, and we've come to be recognized as the 4 southern tribes of Arizona. So I always do this in the manner that we were taught and learned from the beginning of our individual existence here. There's no blueprint for traditional religious practitioners that they use. It all depends on individual how to proceed with what activities. So this day I want to offer a prayer, a blessing song for you in our O'odham language. Opportunity, chanik, good chanik. Momanako kojuko, I sapo anida matmo, juni gidam. Nako kojuko, I avumta. I sapanye that. He didn't juko, I thought there, yeah. The famous smart, my bussy, my gurgok. Was formed, she tonnery, guy, but that good must my e. But he the monaco kojuk. Kobashi sapo a hymn. Either a dwak, a vuji, the gnan commam sekamich come either Jew dam. Which I must masam with a gurga to be Jew. He shone either at the mish with that, but sure oid sword. My papi, they hugger, my ponaco, quite you, quite wound. Oid hugger, my joy bitwa, mitanya gapachada, either dam, humapik, a vusi, jama, hugger, suki come, saptat come, bamjet either humapik. Who said either? A chitacho koi tai, algin your word yet. Who said either, at my tai, who come a word yet. Ta shako we kunanavan, kaho mako, si mama semako, uka. PACHA we couldn't know Kahumuko Shimama Semaka Kam Damakana Nakumama Tiuweg Humapemu Rida Kanya Dama Kanyamaka Kayok Hui Wanye Madama Tashako kewe kunanavan kahumuku shemama semaka hukam. Tashako kewe kunanavan kahumuku shemama semaka hukam. Damakana nakamama siuwek huma pemu lina kanyedama kunyamakaka yok uwivanye medama damakana nakamama siuwek huma pemu lina kanyedama kunyamakaka yok Uy, boye, dama kana nakomama tiyuwek huma pemu rina kanya dama kunyamakaka yok. Uy, boye, madam. That concludes activities for this morning. Everybody have a good day. I was invited to stay and attend the meeting, but I won't be able to join you. So thank you. Yeah.
Thank you. Next on our agenda, we will have our roll call, facilitated by Ms. Kay Hayes, Deputy Assistant Secretary for Infectious Diseases, Director of the Office of Infectious Disease and HIV/AIDS Policy, and Executive Director of PACHA. I'll turn it over to Kay.
Great. Thank you so much. And what a wonderful way to start our day. So with that, I'll start with our roll call of our PACHA members. PACHA Co-Chair Marlene McNeese.
Present.
PACHA Co-Chair John Weisman. PACHA members Greg Alton, Guillermo Chacon, Tori Cooper, Rania Copeland.
Present.
Alicia Diggs. Vincent Guillermo Ramos.
Present.
Jennifer Cates. Mark Meacham. Leo Moore.
Present.
Rafaele Nevadas.
Present.
Laura Platero. Present. Kayla Quimbley.
Present.
Michael Sag.
I'm here.
Thank you. John Sapero.
Present.
Carl Schmid.
Here.
Justin Smith.
Present.
Ada Stewart.
Present.
Daryl Wheeler. And our CDC HRSA Advisory Committee on HIV, viral hepatitis, and STD prevention and treatment, known as CHAC, liaison, Wendy Armstrong.
Present.
Thank you. With our federal partners, Harold Phillips.
Present.
Thank you. Dimitri Daskalakis.
Virtual and present.
Thank you. Alicia Richmond. David Johnson.
Present.
Tim Harrison.
Present. It's not working.
Thank you. John Okutumalade.
Present.
Michelle Sandoval Rosario.
Present.
Rick Havercake.
Present.
Robin Neblett Fanfare.
Present.
Laura Cheever.
Present.
Ernia Hughes.
Present.
Timothy Holtz.
Also virtual and present.
Thank you. Lee Fleischer. Jessica Lee. Maureen Goodnow. Kristen Roja.
Present.
Rita Harcrow.
Present virtually.
Thank you. Edwin Walker.
Present, represented by Andrea Callow virtually.
Thank you. William Dilday.
Present.
Thank you. Caroline Talev. Sharonda Brown.
Present.
And Nellie Gazarian.
Present.
Thank you. Madam Co-Chair, that concludes the roll call.
Thank you, Kay. With that reading of the roll call, just to remind the members, we do have quorum today to proceed on any voting matter before us. I will move on the agenda to turn the floor over to our beloved Harold Phillips, the Director of the Office of National AIDS Policy at the White House. Harold should be keyed up to join us virtually for his presentation.
Great. Thank you. Thank you to the PACHA chairs. Thank you to those of you who have been, to all of the PACHA members and to our host in Phoenix. I am coming to you virtually from the ancestral lands of the Anacostians, the Piscataway, and the Pamunkey peoples, who were first here on the lands along the Anacostia and Potomac rivers, now known as Washington, D.C. There's just too much going on here for me to be with you in Phoenix, so I'm sorry I'm not able to join you. But we'll take this opportunity to give a few updates, and hopefully, as you all go through the meeting and hear the presentations, some of the connections between some of the things that we're doing both in the Office of National AIDS Policy, as well as trying to move the strategy forward, will all be connected. Next slide. Great. So I'm going to give some updates on where we are with the President's budget request for a national PrEP program, some of the updates and the priority of issues that we'll be working to address this next half of the year, and hopefully leaving some time for Q&A and discussions as well. Next slide. Next slide. So as you all know, as part of the FY 2024 budget, the President has requested a new national PrEP program focusing on eliminating the costs for labs, providing the medication, and also wraparound services, and using this program to address the PrEP disparity that we have in our country as well, focusing on the uninsured and the underinsured as well. We've entered into discussions both with federal agencies as well as hearing a lot of feedback from community members on this, and we are looking to move this piece forward. We are having conversations, follow-on conversations about how to turn the CJ into a legislative proposal as well. So more to come on that very quickly over the next coming weeks. The other piece of the President's proposal is requiring state Medicaid and CHIP programs to cover PrEP and the lab costs with no cost sharing as well. So again, thinking about ways that we can expand access to PrEP and address the disparity. So that's what's within the President's budget. The other thing I need to say about this one more time is that this is part of the mandatory side of the budget. It is not from the discretionary side of the budget, and it is not designed in a way that would take resources away from our EHE or our other prevention activities to fund this. So this is in addition to, it's on the mandatory side of the budget, and it is a complement to everything else that we're doing through our regular prevention activities funded through CDC, as well as the EHE funded activities that both CDC and BIPIC are doing to expand PrEP access. Next slide. A couple of updates for you all. We are looking very forward to this summer. CMS put out the national coverage analysis for coverage of PrEP. They've received quite a bit of feedback on that proposal. And we expect that this summer we will get sort of the results of that, and hopefully PrEP will be covered under Medicare as well. The other thing I think that's happened, and so we've been working with them on that piece of it. The other thing that is going on, the National Coalition of STD Directors, they're meeting in New Orleans, attended that meeting, and what I think was really both encouraging and exciting about that is to see how the STI sector really has been using, in particular, a lot of the EHE funding to really do sort of integrated models that are status neutral, really linking individuals both to care and treatment services, as well as linking them to PrEP. So a lot of really great work happening on the ground, and hearing and meeting with a lot of the STI programs. They were also encouraged by the fact that I think they told me I was the first ONAP director to attend the STI conference, but I think it's a symbol of how we are really moving in this direction, sort of close those gaps and really looking at what it means to have a syndemic approach and providing services in a status neutral way. Also, we took advantage of the fact that we were in New Orleans and had meetings with that involved the state, Baton Rouge, and New Orleans, heard about some of the work that they're doing both with EHE and the national strategy implementation. And then we also here in DC hosted a meeting of the PACE officers, which are part of the OIDP team, but they had the opportunity to meet with Prince George's County, Maryland, Montgomery County, Maryland, and wonderful DC, and hear about some of the ways that they are moving things forward, both with the national strategy and EHE. So I think there were a lot of really good things that were shared out of those meetings, and it was really great to see on the ground, especially after not being able to travel for so long, how programs are moving forward and implementing. Next slide. We recently had, and as you all know, we have a U.S. Business Action to End HIV, and the work that's going on with that coalition, our private sector partners. They have, yesterday being National HIV Testing Day, and congrats to everyone who was involved and engaged in National Testing Day. They did a couple of things for employers that are part of the coalition. One, an HIV testing playbook, and really giving them ideas about things that they can do for National HIV Testing Day and promoting it and giving folks time off to go and get an HIV test. So they're continuing to do that work and support. We're also getting new members and new organizations that are being part of the Health Action Alliance and the U.S. Business Action to End HIV. We also, as part of our work to think about PrEP and PrEP access, we had a community pharmacy convening, really looking at sort of the national state of play when it comes to pharmacists being involved as part of the HIV health workforce. What are some of the limitations on sort of the scopes of practice at the state level? Which states have sort of expanded that scope of practice, as well as what are some of the things on the federal level that are still getting in the way of pharmacists having that full practice authority and being reimbursed for the services that they're providing. So we really had a great meeting with our partners that were involved in this, not only the Health Action Alliance, but the American Pharmacists Association, the Elton John AIDS Foundation, and spent all day kind of looking at some of these things and ways that we can really enhance access to PEP and PrEP through the use of pharmacists. Next slide. From that meeting, we expect some recommendations to come forward, and many of those recommendations, some are sort of on the federal level, so we'll be working with our partners to kind of unpack some of that and figure out what we can do. They are also, as part of the U.S. Business Action to End HIV, launching some local innovation hubs in cities of Atlanta and Los Angeles for this year, and really looking at how, with those hubs, they can bring together businesses that are looking to be involved and help in the HIV epidemic with local employers, local government, and CBOs, and really talk about some of the unique ways that businesses can be involved and help support the effort. Next slide. Some of the in-house implementation updates. We continue to do our work with CDC and our community partners on our molecular HIV surveillance and cluster detection and response work. PACHA, which released its resolution this year. We took a look at, since our last meeting, we've done several things. Had a few meetings between me and CDC to take a look at the resolution, take a look specifically at the different actions that PACHA has requested. And as we've continued to do that work, even this slide is a little out of date because we've done 80%, according to recent analysis, of the items in the resolution. They're either in place or being considered. And again, as we talked about before, there are some things in the resolution that CDC will not be moving forward because it's not in the best interest of public health. They've worked on, and we can talk about this, I know CDR is on the agenda, and we can probably talk about this more. I think it's scheduled for tomorrow. Put together a chart that outlines many of the things that are already in place, those things that are being considered, and highlighting also those things that we just won't do in the interest of good public health. So we can talk about that and possibly share that with the subcommittee or with full PACHA members, but we've been working on that and getting that together as well. We've also been doing some work with health departments and other partners to continue stressing the importance of data protections. We've also had some conversations both with White House counsel about strengthening data protections, and we also will be meeting with CHLP to talk about some of the things that they would like for us to consider as part of the language to strengthen those data protections as well. There's also been some effort by CDC that involves some technical assistance and some collaboratives with their grantees around CDR as well. Next slide. This is an example of some of the things that I'm at least thinking about. DC just recently passed a law with some model language, with some language that could be a model for how we use and protect HIV surveillance data. And so really, I think the work of CDR continues, but we also are continuing to look at ways that we can continue to be responsive, protect the use of that data, but continue to move forward in our CDR efforts and address health equity. Next slide. Things that sort of keep me up at night and also are items of concern that have the potential to get in the way of us achieving our overall goals. Looking at the more than 650 attacks on the LGBTQI+ community, I'm very happy about a number of the federal departments that have engaged in pride efforts, including the White House itself, and really ensuring that the communities know that we see them, we hear them, and that we are doing what we can to protect them in their rights, and work in many ways to see what we can do to shore up our protections around both gender affirming care and some of the stigma and discrimination efforts that are going on across our country. We're happy about the stay in the Braidwood case currently, and the White House, working with the Justice Department, will continue to do what they can to ensure access to preventive services and look at this as another attack on the ACA, which has been the law of the land for over 10 years. We're also very concerned, and this is a question for PACHA. Our PEPFAR colleagues have been engaging in a bid for reauthorization. The process has not been as clean and smooth as they would have liked, and PEPFAR is actually being attacked. And one of the things that I was asked was whether or not there was something that PACHA could do, either collectively as a body or independently as members, or independently in you all in your roles and your capacity, to really and truly talk about the importance of PEPFAR to the overall global HIV epidemic, and also the counter narrative of what PEPFAR is versus what PEPFAR is not. PEPFAR is not a program where its funding can be used for abortion services. It never has, never will, and there are systems in place that prevent that. But there is a narrative that is saying that it is a tool for abortion in African countries that is getting in the way of a clean reauthorization process. We continue to look at and look at ways to also, in that same vein, collaborate with our partners on the reproductive rights sides, on the gender-based violence side, and really looking at these issues holistically and systemically, and that includes also the issues of gun violence as well as housing. So again, really encouraging a lot of coalition and partnership building, especially as we think about social determinants of health, the health outcomes that we're working toward, and what this all means for our nation at this particular time. Next slide. Speaking of social determinants of health and quality of life, we are also going to be releasing data later this year, really looking at our quality of life indicators. We have also had some conversations with the National Working Positive Coalition, representatives from the Department of Labor, to really think about and talk about the role of employment on quality of life, and really looking at that. So more to come on that. Also, CDC and HUD held a roundtable on HIV housing that really highlighted the importance of both an integrated approach and really thinking through what status neutral housing might or could look like. There were lots of good ideas about ways to braid funding streams, things that we need to think about on the federal level to make it easier for programs to implement such approaches, and the necessity for more of those approaches too. Next slide. Also, we've been working, and hopefully you all have seen this, really working to tell the story of the NHAS and the EHE initiative, and really sort of focus on some of our accomplishments and the impact and some of the work that has been happening in spite of COVID and also as a result of COVID as well. We expect a NHAS progress update that will come out toward the end of the year. That's the wrong year. It'll be the end of 2023. That'll give some high-level data points and a narrative that sort of talks about some of the implementation progress as well. Next slide. Before I go into discussion, one of the other things that sort of keeps us up at night is MPOX. And I just want to say that, we are aware of the cases in Chicago, cases in Los Angeles. HHS and our MPOX coordinator, Dimitri Daskalakis, has pulled together a interagency group to function as sort of a tiger team to really work with jurisdictions to ensure that vaccine is being equitably distributed to the populations that need it most. So a lot of that work started over the last couple of weeks and will be ongoing during the summer, really keying in and focusing on different festivals and events, especially where Black and Latinx individuals are present and need either that one shot or that two shot. And I think a lot of this also lines up with the work that CDC has done on its website around getting the community excited and prepared for summer, and different ways to protect yourself from both HIV, STIs, and MPOX, and other necessary vaccinations. So I think that's it for me.
Thank you, Harold. Thank you for those very important updates. We do have a few minutes, and so I wanted to extend an invitation to PACHA members around the table if you have comments or reactions to Carl. Go ahead.
Thanks, Harold. It's Carl Schmid. Thanks for all you're doing. So much with, I know, no staff. And thanks for all your continued highlight of putting together a national PrEP program. I think we have to be realistic that something of that magnitude, a mandatory program, is not going to pass anytime soon in the Congress with the current environment. And so I would just encourage the White House and you to, make sure that we're doing more PrEP work. And we really saw the need for it yesterday when we visited the clinics. We still need a national PrEP program. But in the meantime, I think there's more that can be done within the resources now at the CDC, the community health centers, to make sure we get that continued funding, that we make sure that there's more focus on PrEP with the resources that we now have. So just wanted to get your comments on that. And then the other thing that, we're hearing, a lot of people are concerned with the national PrEP program that you proposed, that focusing in the Ryan White clinics, it's going to take away from care and treatment for people living with HIV. And just wanted to see if you had any comments on that.
Yeah, thanks for that question, Carl. I think a couple of things I would say. Absolutely. The issue of PrEP access, understanding demand generation and navigating the systems for PrEP is very layered. And with the National PrEP program being sort of an additive piece of this pie that really targets those who are uninsured and underinsured and providing access and coverage for them, it is only one piece of that, one slice of that pie. The other slices and the other things to think about, CDC is going to, later this year, release its new funding opportunity announcement for its flagship prevention funding. And we all have, and many of you all and the community has been in dialogue with CDC about some of the needs and what that needs to look like in terms of our overall prevention efforts. So we will see some changes. They can't discuss what those changes will be, but we will see some changes, I think, that will also help move us forward in achieving our PrEP uptake goals overall. I think the other thing that we're seeing is, and this is one of the reasons why I'm really interested in looking at sort of what are some of the federal policy and program issues that are getting in the way of pharmacists being part of the solution, and also thinking about what is happening at the state level, because we do have some states that have expanded scope of practice for pharmacists, and yet because they're not either being reimbursed, or there's still some uncertainty about the model or about the awareness piece of it. So really, I think, and also sort of the Medicare piece and the CHIP piece. So pulling at a lot of different levels to increase PrEP access and uptake, and PrEP maintenance is definitely part of the equation here. I think the other thing that I would say is, we know for a lot of years, the Ryan White program has been flat funded. This additional funding stream to provide HIV prevention services in those settings, I think on the front line, I think it will give the opportunity to provide more holistic and comprehensive services to not only those who are HIV negative, which this funding stream targets, but also there may be ways to enhance some of the existing Ryan White services and their availability within those settings as well. I think it is, for me, it is sort of an overall sort of thinking about what it might look like in those settings to be able to provide comprehensive sexual health services for those who are positive as well as those who are negative.
Thank you, Harold. I'll invite John, Vincent, and Justin to be brief with their questions and comments, and then we'll move on. Thank you.
Hi, Harold. John Weisman. Thanks again for your amazing leadership and all the work that you've been doing. It's impressive, and I know the whole country benefits from it. Appreciate the updates on the molecular HIV surveillance work that's ongoing with your office and CDC. It's exciting to hear that you're looking at the recommendations and actually identifying sort of which ones are already in place or being considered. To that end, I'd like to actually invite you and CDC to engage the molecular HIV subcommittee, with more information about that work and the things that are being done. One of the things we heard, certainly, I think, and left from last meeting is that we need to increase the communication on sort of what exactly the plans are to move forward with CDC. So I think that would be a great way to move forward. And just think we need to be careful about language and discussion when we talk about recommendations and whether they're in the best interest of public health or not. Certainly there is room for sort of disagreement on what's best, but I think that we're all after the same goal, and I think increased contact with the subcommittee will benefit all of us, so would appreciate that.
Absolutely. As we work to prepare the chart outlining how things are moving forward and what things have already been done and what things are sort of being considered as part of the future NOFO or being considered, we have wanted to know what is the best way to provide that to PACHA. But since our last meeting, we thought it would be really helpful to kind of walk through all of those recommendations and provide more additional detail. So happy to do so.
Thank you. Vincent.
So Harold, this is Vincent Ramos. Thank you so much for your leadership, and I'll just echo what others have said. Terrific work, and obviously we're all indebted to you. Just a couple of quick comments. And so one, I do want to celebrate the work that's happening with pharmacists. And as you might predict, that my interests are really on the full health workforce. And I've got to keep on sounding the drum, beating the drum, making noise about the 4.3 million registered nurses in the United States that continue to experience sort of underutilization in terms of the national response around HIV. And I'm perplexed by why we're not sort of looking at that in a much more focused way. It's a low-hanging fruit, and it's completely essential to thinking about how we can respond as a country. I want to say also just really briefly that I love the idea of the impact reports coming out around EHE and NHAS. I would say that recently I've been looking also at the programs, and I'd love to have conversation about what's going well, but then also where are some of the gaps and how can we be more precise in our work moving forward around being very open about those gaps. And then lastly, I'm disturbed by whatever the trouble has been with PEPFAR. Would love for PACHA to try to see what we can do. Just came back out from a trip from Tanzania and Rwanda, and just to illustrate the point, visited many HIV clinics that have had long-term relationships with my institution, where many of those clinics have one physician and an army of nurses. And there's evidence that is very substantial in PEPFAR and globally around antiretroviral rollout that has been driven primarily by nurses. And so I was so humbled seeing what they're doing in maternal child transmission, on PrEP, and also on keeping people virally suppressed. It's absolutely amazing, and the U.S. needs to kind of get on board.
Absolutely. Thank you for that, Vincent. I think two things just quickly. I think, yes, and the fact that you were in Rwanda, which is one of those countries that has reached epidemic control, is truly amazing. I think, too, in answer to the question about pharmacists, there have been a number of bills that were introduced at the state level around pharmacists and pharmacists providing PrEP and PAP. I don't know that we have that same sort of momentum in the nursing field. And I'm very much, in the corner and in favor of nurses, and have seen a lot of those nurse-initiated PEP, PrEP, and treatment models. And so we probably need to spend some more time trying to figure that out. But there seems to be sort of this national momentum around pharmacy that we have sort of attached ourselves to in order so that we're not left behind and we can influence the dialogue at this time. But I think the same should happen for nurses.
Absolutely. And Laura will actually be the sequel to the last comment. So we'll go Justin, Laura, and then we'll move on. Thank you.
Thank you, Harold, for that really comprehensive update. just a quick addendum to the comments that John offered earlier about our work together on MHS and CDR. I think it will be important, really looking forward to kind of the chart that you mentioned, but also want to make sure that we are having updates with the subcommittee, but also with the community at large. So trying to make sure that we are doing what we can to make sure that there's transparency all around. So I just want us to invite some more conversation with not just the subcommittee, but also with community, specifically thinking about the networks of people living with HIV that have brought a lot of the concerns. So just want to make sure that we're ensuring transparency across the board. But thank you for that great work. I'm really looking forward to kind of that crosswalk that you mentioned. Thanks so much.
Thank you. Thank you, Harold. Laura Platero, question. Is there anything Indian country can do to increase White House awareness of American Indian issues or to increase resources and support for American Indian communities?
Hi, Laura. I love that question. One of the things that I didn't mention, because we're in the very early stages of thinking through this, and we've been talking to Rick Haverkate. I'm not sure if he's in the room and with you all. But we've been talking about trying to have a White House meeting around sort of HIV and Native American and tribal peoples. Some of our data seems, and we want to really look at this data. You know, we've got some recent data that shows that a majority of those with diagnosed HIV are in our Ryan White systems as well, receiving care in Ryan White systems. And they may be virally suppressed, given sort of what's happening within the Ryan White system. So really wanted to have a meeting to focus on how do we get to this last mile of either elimination or micro elimination of HIV as a public health among Native and tribal peoples? And is that a realistic goal, and how do we get there? And I think some of it is looking at a syndemic approach and thinking about the role of STIs, viral hepatitis in the community, and really how do we mobilize our EHE, our Minority AIDS Initiative funding, IHS, and other key partners who are those that need to be at the table and realize that we can achieve this goal among Native and tribal peoples. So we're thinking about that meeting in August. We're in the very early stages of planning, and also thinking about who are the right leaders that need to be in the room that can influence change and mobilize us all around these particular goals.
Thank you, Harold, and I hope everyone will join me in thanking Harold for his time and his updates today. We will proceed on our agenda. Next up, I am really excited, and I don't think I can overstate the energy and effort around PACHA-based principles to address zero HIV stigma. That work has been led by Dr. Leo Moore, PACHA member, as well as Rania Copeland, PACHA member, over the past month or so. And so they have been knee deep in leading a smaller group of PACHA members through this process. And so I really want to turn the floor over to Dr. Leo and to Rania for them to share with us what they have and to ask for PACHA member support. So Leo.
Thank you, Madam Co-Chair. Good morning, everyone. So we are really excited to bring forth a resolution in commemoration of Zero HIV Stigma Day, which is on July 21st, 2023. The name of our resolution is From Vision to Reality, a Call to End HIV Stigma. I first wanted to share a bit of context. So the Stigma and Disparities Committee had our strategic planning meeting in February of 2022, and the committee decided to draft a document that envisioned a world without HIV stigma, and specifically focused on what we all can do to end HIV stigma. We convened our subcommittee in May and June to draft the document. The subcommittee decided that this would be a one-page document that could be posted in healthcare organizations, social service organizations, and others. And our goal was to use plain language throughout the document so that it could be accessible for readers at all levels. I I also wanted to mention that in keeping with our longstanding commitment to engage community as both thought leaders and action partners, we engaged the community twice regarding the document. First, to inquire about existing models and best practices that we should consider in the development of the document, and two, to provide feedback on the initial draft. Lastly, I'd like to take a moment to thank both our PACHA co-chairs, Stigma and Disparity co-chairs, subcommittee members, and last but certainly not least, our community partners for their efforts in developing this document. I'd also like to thank the PACHA administration team, Kay, Caroline, Emily, and others for their support. I'm going to turn it over to Rania.
All right. We're excited to introduce this. I will read it and then open it up for comment. In recognition of Zero HIV Stigma Day, July 21st, the Presidential Advisory Council on HIV and AIDS joins the movement to eradicate destructive and harmful attitudes, behaviors, judgments, and policies towards people living with or vulnerable to acquiring HIV. In collaboration with other global and domestic communities of people who continue to experience negative consequences of irrational beliefs, myths, and biases, we call for an end to HIV stigma. What is HIV stigma? HIV stigma is negative attitudes and beliefs about people living with HIV. It is the prejudice that comes with labeling an individual as part of a group that is believed to be socially unacceptable. The HIV stigma that a person experiences can be worsened by their individual characteristics, such as their race, ethnicity, sexual orientation, gender identity, and other factors. How is HIV stigma harmful? HIV affects everyone, regardless of sexual orientation, race, gender, or age. Stigma can worsen a person's health conditions and delay or even stop them from getting tested and treated. Stigma can lead to social isolation, depression, and anxiety, and impact professional growth and development, trapping a person in a worsening cycle of illness. HIV stigma and misinformation also unfairly shapes systems and policies. For example, the majority of states have an HIV-specific criminal law or use their general criminal laws to unfairly prosecute people living with HIV. What can we do to end HIV stigma? Individuals, educate yourself about HIV, check your biases, and be conscious of the language you use when discussing people living with HIV. People living with HIV on treatment with an undetectable viral load cannot sexually transmit HIV. Undetectable equals untransmittable, and frees them and their sexual partners from the fear of transmitting HIV to their sexual partners. This fact has changed what it means for people living with HIV to live and love with HIV. Talk openly about HIV and sexual health with your sexual partners, community, and your healthcare provider. Communities. Community leaders should learn about HIV and voice their support for HIV testing and treatment, as well as the human right of treating people living with HIV with dignity and respect. Community settings should host events where communities can learn the facts about HIV from people living with HIV themselves, as well as other experts. Normalize the topic of HIV by placing posters, pamphlets, magazines, and other information about HIV in your community site. Healthcare settings. Healthcare settings should provide ongoing HIV-related training and education to the entire staff, with an emphasis on common misconceptions about HIV and HIV-related stigma. In addition, healthcare settings should develop and enforce institutional policies to protect persons living with HIV from discrimination in their facilities. People living with HIV. Your very existence is enough. Your ability to thrive in your community is important. Partner with your healthcare provider, family, and friends to benefit from medical innovations and support that ensures you are able to live a long and healthy life. All of us. We can do our part to end HIV stigma through our individual actions, such as using non-stigmatizing language and knowing the facts about HIV, as well as part of collective efforts to ensure policies and systems support people living with HIV are able to live long and healthy lives. HIV stigma will persist if we fail to recognize the humanity of people living with HIV. To learn more about ending HIV stigma and Zero HIV Stigma Day, visit HIV.gov. And then we included, I think, 4 resources around HIV stigma from HIV.gov, from CDC, the Center for HIV Law and Policy, and the United States People Living with HIV Caucus. And with that, I will open it up to see if we have comment and edits from PACHA members.
And just a reminder, we do have Rebecca in pure process fashion there in the back. She is making live edits for us as we move along. So please be patient as she is typing and incorporating some of the feedback and comments. But I will allow others to chime in. I see John and I see Carl.
Great. Thanks for this amazing work. I'd like to just add one suggestion of adding a little bit of language under the what is HIV stigma, the last sentence where it says sexual orientation, gender identity. I'd like to add drug use history. And then other factors. So just add drug use history if that's acceptable to folks.
That's great.
I agree with John. Excellent proposed resolution. Well written. I do think since PACHA is a body that advises our government that we should propose a section on what the government can do to prevent stigma and speak out against it. So I have I hope not a very long 2 sentences that we could try to get in. Welcome to edits to make sure it fits if it's all acceptable. But do you want me to read it?
Please do.
Okay. Are you ready back there? Thank you. Okay, great. So add a new section on, maybe after people living with HIV, entitled Governments, ensure through programming and grants that HIV is addressed in a non-stigmatized manner. And there are programming and grants that focus on anti-stigma campaigns.
That focus on
anti-stigma campaigns. Sorry, I should have looked up to see where you're typing.
We'll do this together.
And then new sentence. Government leaders should use its bully pulpit. Bully pulpit.
didn't think the other one made sense.
when individuals or entities take actions that promote HIV stigma. Welcome to any edits to get it down.
While folks are thinking, we see Dr. Stewart.
Yes, thank you. Again, excellent draft. And I just had one small edit, and that is in the bullet where healthcare settings, the last sentence that states enforce institutional policies. And I think adding procedures after that would encompass other things that institutions can do to protect persons living with HIV. So small edit.
Thank you. Can we scroll back over, Rebecca, just so that we can see the proposed language for governments? One potential edit I see for, instead of bully pulpit, I want to propose positions of authority. Government leaders should use their position of authority when individuals or entities take actions that promote HIV stigma.
I recognize PACHA member Mark Meacham.
I know originally the intent was brevity on the statement, so that you capture it a little bit. But as Carlos added a government, or recommending to add government, it seems that the private sector might be a sector, particularly in light of Harold's comments, that we might add a sentence as well. And so I'm trying to draft that in. It could take me more than a few seconds, but I do think that given the other additions, that might make sense. It should be vision on the private sector / business.
We can just work on really small font. Don't worry. Fit it on one page.
Is there an opportunity to make it employers and government, or some way to pull those together?
Yeah.
I do think they're different sort of entities. The way we have individual and community, so yeah, that's society, and we have government. I do feel like it is a separate model.
Understood.
I see Vincent and Justin.
So just in the spirit of, I guess it was Carl that started us, but adding a few words here and there, you guys can reject this. But under this section that says healthcare settings, might it be possible to consider a small edit that includes healthcare settings and health profession training programs, so that what is reflected is that students are also getting this information? And it would just require a couple of words. And so it would just say healthcare settings and health professions training programs should, and then instead of saying the entire staff, you can say to the entire staff and future healthcare workforce.
I love that.
Mm-hmm. Justin?
So I have some very, very, very minor wordsmithing. So in the last section on all of us, so where it says, as well as part, I would say as well as taking part. And then where it says living with HIV, instead of are, I would say to be. I think it makes it more grammatically correct. Maybe so. That's it.
Oh, to be able
Or just are.
Oh, okay.
Okay. Yeah.
Okay.
So I see Laura Cheever, so I want to invite her, but I also want to welcome any edits or comments or recommendations from any of our federal partners. But thank you, Laura. Go ahead.
Yeah, so I don't know how proper it is to make actual edits, but I would ask Carl to consider the role of policy and legislation that's part of government as well. That seems to be missing from that.
Did you hear that comment? So really it's centered around in as a part of your government section, adding something very explicit around policy and legislation. Yeah.
Should we say legislation? We don't, yeah.
And maybe you could say ensure through programming, grants / policy and legislation.
Mark, have you gotten closer?
I think so. So, what got to do what businesses should use their ability to engage with employees, customers, and communities to support them.
Yeah, sorry. So, use their ability to engage with
employees, customers, and communities to support people living with HIV and efforts to end the epidemic. I was trying to keep it short. I understand things around stigma, but I think I keep it to 2 elements: the recognition of humanity as a support of people living with HIV, as employees, as a part of the community, and then also the support and ending the epidemic.
Should it be business, or do you think it should be private sector? Private sector.
Any other comments, recommendations, or edits?
Yeah. Madam Chair, I would move approval with the authority given to the individuals who are primarily responsible for this. Some authority to edit a little bit to get it to the 1 page. The goal is people want to be able to get this up on walls in a 1 pager. So without sort of losing content, that would be my my motion.
And since this recommendation is coming from committee, I will accept that motion if you so agree. This is your committee, okay? I see nods. So all in favor of approving this statement of PACHA principles around zero HIV stigma, all of those in favor, please say aye.
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 Thank you for those online. Appreciate that. And then for the rest of the group and for formality, any abstain or no's? No dissensions. Okay. And any abstentions? All right. Let's give a round of applause.
Thank you everyone for taking me down.
So PACHA members who are online, in the room, we're not seeing the photos of everybody in hand raises. So if you want to join in on the conversation, please make yourself known. Feel free to unmute yourself at an appropriate time and indicate that you would like to make a comment.
We see you, Raffaele, and we hear others, so thank you for joining us virtually. And in the spirit of moving our morning forward, we will go to our what we've been looking forward to, a bit of overview and level set around ending the HIV epidemic in American Indian and Alaska Native communities. We have our very own PACHA member, Laura Platera, and Rick Haverkate, who's going to provide us a bit of an overview that I think it's important as we move throughout the rest of our conversations of today. So I will introduce them both collectively, and then I will turn the microphone over to them as they will share their own sort of perspective around this work. Laura Platero is a citizen of the Navajo Nation, currently living in Portland, Oregon. Ms. Platero has spent at least 20 years serving tribes and American Indian community in various advocacy roles. She is currently the executive director of the Northwest Portland Area Indian Health Board, a public law 93-638 and nonprofit organization with 70 staff. Her passion for Native health was instilled while working as deputy director of the National Native American AIDS Prevention Center, and was the heart of HIV prevention, treatment, training, and resources for these communities and Two-Spirit people. Rick Haverkate is an enrolled member of the Sault Ste. Marie tribe of Chippewa Indians in Michigan and grew up in the land of his ancestors along Lake Superior's shores. In 1993, he earned a Master of Public Health degree from the University of Hawaii. His public health work has been focused almost entirely on American Indian, Alaska Native, Native Hawaiian, and Pacific Islander populations. He has specialized in operational management in the fields of HIV/AIDS, maternal and child health, commercial tobacco use prevention, health promotion and disease prevention, and community capacity building. Mr. Haverkate currently works for the Indian Health Service as their National HIV/AIDS Program Director. I turn the floor over to Rick and Laura. Thank you.
Thank you. For my Navajo relatives here, Yate Epidemic, my clans are Salt clan and I'm Mexican, and Edge of the Water clan through my maternal grandfather. So just wanted to share that. So thank you, Maria, for being here. Maria Dadger is the executive director of the Intertribal Council of Arizona. As is our way, we always meet and interact with the local tribal organizations when we come to community. And I really appreciate you having Mr. Lewis do that beautiful opening prayer for us. It really touched my heart. I was completely moved by it. And he truly represents the spirit and beauty of our people. So tribal sovereignty is really complex. I have a law degree with certificate in Indian law, and I'm going to try to explain in just minutes a few very key concepts. I really hope it opens your mind to want to know more about tribes and tribal sovereignty. So if we can just pull up my slide set quickly, I'm going to kind of just go through. It's really going to be, oh, it disappeared. My slide set disappeared from the screen. Anyways. So, tribal sovereignty. So tribal sovereignty is important to know in working in HIV and AIDS. We often, in a lot of the work around HIV and AIDS, tribal nations tend to get excluded in the work and the conversations. So it's really important to understand the framework and how to access and contact tribes. So in this very short presentation, and again, I'm not going to be able to go through all the slides, these were the topics I planned to cover. I'm going to actually go ahead and move to the next slide and just jump right in. I had a Q&A for you, so I'm just going to have you think about the answers to these questions and see if you know any of the answers. Keep going, see how many you know. So I just want to pause on this slide for a minute. I often identify as American Indian myself, mainly because I really think it's important to honor the history of our people and the term that's been used in all of the legal doctrine behind the status of tribal nations and who I am. So I will say I'm American Indian. I also say I'm Navajo. Those are the two terms I use. I don't use Native American. That does include other indigenous people, which I do support and, of course, appreciate that definition as well. But for me, I use the definition of American Indian. I also don't really use the definition of indigenous. I support anyone who uses that definition. You'll see me probably on occasion use it too, but I generally don't use that. We also refer to our tribal nations as tribes, nations, bands, pueblos, communities, and native villages. It really depends on the community you're in, so it's important to know that as well. Next slide. Okay, this is a very complex slide. I'm going to say, I hope, again, it opens your mind to learning more. There is a historical timeline of major events in Indian healthcare. If you can see the bold terms that are in the center of this diagram, the policy of conquest, treaty making, assimilation, reorganization, termination, self-determination, these are all what are considered Indian policy periods. These are periods in which the federal government changed its position on tribes and flip-flopped back and forth between policies that were really negative. Sometimes they were negative again, and then they flopped to be a little bit more positive. But again, this really makes up kind of our history. Like, we're the only people with an entire body of law that basically addresses how the United States will deal with, work with tribal nations and American Indians. So I just wanted you to sort of see kind of how complicated it is. It's a very complicated area. You'll see before 1492, full tribal sovereignty, things changed, things moved back and forth. And again, tribes are still sovereign nations, but it's definitely defined by this huge body of law. The other piece that is really important, and you will hear tribes talk a lot about, are treaties. And treaties, I'm going to touch on that in just a minute. But if anything, what I would love for you to take away from this is really there have been so many changes impacting our tribal nations. Our people are very resilient. We have beautiful cultures, ways of being. We value our families. There's just a lot to know besides the health disparities that we always hear about. Let's move to the next slide. So tribal sovereignty, just a few bullet points for you to just have here. Tribal sovereignty, the whole basis of that, of course, it starts with the treaties. Treaties basically are the supreme law of the land. So it's just really important to know that that's sort of the starting point that for the federal government to acknowledge tribal sovereignty. And you'll see here on the right just why treaties were made. There's various reasons why tribes negotiated with the federal government for treaties to be in place. There's 374 Indian treaties that exist, and healthcare is one of them. You'll see there on the right. So let's move on to the next slide. The other thing you'll hear a lot about is federal trust responsibility. Tribes will very often say when you're in meetings with tribes, it's a federal trust and treaty obligation. Trust is one part of it. And again, the trust responsibility is defined by a huge body of law. So it's collectively defined by all of these sources here that I have named. And so the main thing that it means is that the federal government will respect the sovereignty of tribes, protect the tribes, and provide for the well-being of tribes. That's sort of at the core of it. And depending on the area, there's other sort of extensions of the trust responsibility. Here on the right, just an example, and our chairman mentioned this a little earlier, that tribes, Indians, have a political status, not racial, when it's tied to the unique federal obligation to Indians. So you will very often hear in meetings, tribal leaders say, we are not a racial ethnic group, we have political status. So that's where this comes from. It comes from this very important Indian law case. It was reaffirmed just recently. It was a huge victory for us in Holland versus Brackeen. The Indian Child Welfare Act was upheld by the Supreme Court. This was a major celebration for us. So just wanted to say that we're still celebrating. It's really exciting for us. Next, please. Okay, trust responsibility for healthcare. As I mentioned, healthcare is part of the trust responsibility of tribes. So you'll just see here, the federal government's obligation to healthcare is really on HHS, the primary agency that provides healthcare to American Indians and Alaska Natives is the Indian Health Service. And so the Indian Health Service is significantly underfunded. We're funded at $6.9 billion. The tribal request for full funding, when you really look at the need, it's $49 billion. So it's really significantly underfunded. Tribal requests for funding, that make it up to the administration, go through a body called the National Tribal Budget Formulation Work Group. Tribal representatives are made up of that. They basically decide what the priorities are. With such limited funding, HIV cannot get to the top of that list. It's impossible. So it is so important for all of the other agencies, CDC, SAMHSA, HRSA, every agency to commit HIV funds to tribal communities. There is no way the Indian Health Service budget can ever prioritize HIV with the budget we have. And, we continue to ask for full funding. We don't know if we'll ever see it. Okay, next slide. Okay, there are several requirements for tribal consultation in terms of the authorities, so statutes, executive orders. HHS has a tribal consultation policy. It's a picture of it is here on the right. Every agency has tribal consultation policies in terms of how you work with tribal nations. And then there's different mechanisms for a tribal consultation. So it's really important to know there's actually policy in place for how HHS and all the agencies work with tribes. Next slide, please. There's also this whole system of tribal advisory committees across HHS. So like PACHA, there's a similar one called the Secretary's Tribal Advisory Committee meeting. It's a 2-day meeting. It's in DC 4 times a year. The secretary usually comes to that meeting on the second day for about an hour and meets directly with the elected tribal leaders at that meeting. That's the highest level meeting tribes have access to, the secretary on healthcare. And then there are several other, you'll see I have a bunch of other agency tribal advisory committees that exist. And on these, again, tribal leaders sit on every single one of these. So my organization, Maria's organization, we work with all the tribal leaders on all of these for our area and prep them for these meetings. So these are really important meetings. This is how you get access to the tribal leaders and get priorities for HIV and anything, substance use, anything is really through any of these committees. Okay, next slide. Just wanted to share resources. I highlighted my organization here at the bottom. Maria's is Intertribal Council of Arizona. But the epicenters and tribal orgs, regional health organizations are here to help and support PACHA and any one who sort of wants access to tribal nations. Next, please. One more slide. Next. Okay, so takeaways. Important to understand the status of tribal nations and the unique structure of the Indian health system. Underfunding of the entire Indian health system and significant health disparities really impact the focus on HIV. Tribal consultation is critical. Know about the HHS tribal consultation policy. Tribal advisory committees can be a resource on HIV and AIDS funding. And then the regional health boards and tribal epicenters are a resource and are very connected to tribal communities because it is often hard to get into contact with tribal nation directly. We are a good place to start. And last slide. I think I did that pretty fast.
And actually, we will thank you, Laura. I think that was very helpful and really centers, I think, how and what considerations PACHA needs to have as we think through how can we help support and influence some of the recommendations that you're making. We'll go directly into the presentation by Rick, and then after that, we'll open the conversation up for folks around the table, PACHA members and our federal partners.
All right, thank you. Thanks so much, Laura. Incredible presentation. Thanks for setting the stage for that. I think we had planned to do a little back and forth, and I was going to talk about tribal sovereignty, but obviously she's a pro. I could never top that. So I'm going to talk about something else that may not have been on your agenda. I'm going to talk about something we call the IndigiHOS. We've created an indigenous syndemic strategy. So we're combining the national HIV strategy, national viral hepatitis, and national STI strategies into one indigenous strategy for the syndemics. We did this, a lot of it's based on what we learned about how we do work with tribes because of tribal sovereignty. But we didn't do this to replace anything. We did this to bring them together. Those three strategies, we prioritize all of them. But we worked with a group of tribal folks representing all of Indian country. We were funded through the Minority HIV/AIDS Fund, thanks to OIDP, Kay, and Tim for all their support. And then we met for about a year and a half committees to design this incredible strategy. If I have time, and John back there at AV, I don't know if you can go to the next slide, and will that video play, that YouTube video? I just wanted to show you, there's some questions just about how we get access and how we talk about HIV in Indian country. So a quick little 30-second YouTube video that we're in the process of making sure everyone sees. We can play that. There's something called Good Health TV, and we've got it in our waiting rooms around Indian country. You have to subscribe to it, but we help people support that. If we can't play it, it's okay. We can show it later. We can go to the next slide. But if you have the ability to go on YouTube and just search, let's talk about HIV, you can see that video, but we can skip to the next one. Again, something else that lives on the web on YouTube is we created a video for statistics in Indian country on HIV. I think that's one of the things we have to talk about a lot is what's the data? What do we know? What's happening with our own communities? How do we compare to other groups in the country? So that last slide was a good way to do that. This one, if you want to take a picture with your camera, with your smartphone, it'll take you right to the IndigiHOS, that national syndemic strategy I spoke about. So take a little picture of that. We'll give you a second here. It lives on Indian Country Echo. We also talked about that a little bit yesterday, so I'm glad I can make a little plug for what Indian Country Echo is. That's the way we really do a lot of our training for our providers around the country. We didn't invent Echo, of course. University of New Mexico did that, but we incorporated that into our daily communication with our providers. Heather, you spoke about that yesterday at PIMC in our site visit. It's an incredible tool. Next slide. So that will take you to the Indian Country Echo page directly through the IndigiHOS. But now this next language here, you'll recognize I didn't invent this, but we copied it. But we envision a world in which all Indigenous people are healthy in mind, body, and spirit. The spread of HIV, STIs, and viral hepatitis is prevented. Every person knows their status and lives free from stigma and discrimination. And every person has access to high-quality, holistic care that reflects Indigenous values, promoting relationships with each other, the land, and all beings. And go. So some of the core values that came up during that meeting is we talked about things like tribal sovereignty and land recognition and my slide is too small to see some of those words in here. I can't even do it. Honesty, truth, sharing, and even one of the Hawaiian terms, because we didn't just stop at American Indian Alaskan as we included our indigenous cousins in Hawaii, and they were part of this indigenized version for us. And I have to say that I use that term, and I'm not supposed to anymore. Indigenized. I was educated about that term. I should use indigenous, not indigenized. We didn't take something and then stick a feather on it and call it native. That's not what we should be doing. We started from a place of knowledge, of cultural awareness, where people live, where they work, where they serve their own communities, and we developed a strategy that's indigenous. We didn't indigenize it. So catch me on that if I do that again, please. Next slide for me. So some of the strategy components you can see by design relate to our goal and the types and levels of interventions. For example, the committee painstakingly made direct paths from prevention, treatment, diagnosis, and response, and we tied those directly to individuals, family, community, and the healthcare system. Just another example, I wanted to show you some of these clips. Maybe we can play them later throughout the day when we have breaks. Another thing I really want to talk about that goes along with this strategy is something called native test. And it's not to test if you're American Indian. It's a test for at home specimen collection and testing for HIV. Cody Knight is here from the Southern Plains Tribal Health Board with their Southern Plains Tribal Epidemiology Center. We funded them, again, through MAIF dollars, to develop a national test that went along with some of the work that had already been done in Alaska, I think. And so you might have picked up a little flyer out front, but this shows you some of the maps of where we've gotten that test, where Cody and his staff have really gotten that test out. You can text the word native test to 55251. You can all do it to see how it works. It's something that we're getting around Indian country. It's national. We started off small, but you can see it's just really expanded across the country. We're very, very proud of that ability for people to have that private in-home testing if they'd like it. We also link them to services. We talk to them about PrEP. We have all these great texting services where people can find out about a lot of things. We have something where parents can learn how to talk to their kids about sexuality. And then to go along with that, on the back of this, there's something called I Want the Kit. And we're working with Johns Hopkins University to provide in-home sample collections for things like chlamydia, trick, and what's the other one? Gonorrhea. We don't have the ability yet to do in-home syphilis, but we're getting there. So we like that. And that's a state-by-state thing. We've got, I think, 11 or 12 states signed on for that now, because we don't just send them the test. We also follow up with positives and connect them to care. And that's a really big job. And Cody's group is helping us do that. So if you have questions about the indigenous HIV, STI, Hep C, syndemic strategy, please let us know. Very happy to talk with you about that. Get to know it. We've already heard from some of our communities. They're using that to promote their work locally. They're using it to apply for funds, to mold their programs. And really, I think it's a great way that we are dovetailing the work that's already been done at the federal government and bring it to our Native communities. Thanks.
Thank you, Rick. That was very helpful to give a little bit of an overview for those who have not had an opportunity yet. We did want to ensure that we shared the Epidemic strategy and plan with members before the meeting. And so I really want to just extend a couple of minutes for one or two comments, reaction, questions for Rick and or Laura. Any questions? Ron, okay.
Thank you so much to the both of you guys for your leadership and the education that you give us. I'm interested, Rick, in the Native Test program and what kind of reaches it had and what have been some of the successes, and if there's any challenges that you would want to share with us.
Great, thank you. And I could let Cody talk about that, but in the essence of time, you can talk with Cody later, but I can just answer briefly that we've had an incredible success. You know, there are some statistics on here where we've been doing it for with 38 tribal partners just out of Oklahoma. We have received 3,400 orders for HIV self-test kits. This is in its kind of early stages, right?
Amazing.
But we've been able to link 27 people to PrEP care. We've distributed over 10,000 condoms. So it's incredibly successful, and it grows and grows and grows.
Yeah, I think one of the things with at-home testing that I continue to advocate for is making sure that it is culturally responsive, and even seeing native tests. I feel like that's very much from the community, and it identifies. And so I think this is a great model for how you take at-home testing and make it relevant for communities that are most impacted. So thank you. This is great.
Thanks for your support.
Hey, Laura, I wanted to ask you, you shared a map of the breakdown of the 12 regions. How come there's so many regions that are delineated on the West Coast, but then the entire East Coast was just one region in itself?
That's a good question. That's a good IHS history question. They are the ones that came up with the area designations. Yeah, I don't know why they decided that when they established the areas.
But you can just see how vast that area is, called the Nashville area, from Alabama to Maine. And can you imagine covering that with one area office? Yeah.
Incredible. So again, let's thank Laura for that very important level set. Next, we'll hear from Maria Dadgar. Okay, Dadgar. Okay. And let me introduce her, and we'll spend a few moments hearing about her and her work. She's an enrolled member of the Piscataway tribe of Accokeek, Maryland. Ms. Dadgar has worked in the fields of higher education, nonprofit executive management, and tribal economic development for more than 30 years. Throughout her career, she has been involved in advocating for public policies and legislation on behalf of tribal nations regarding economic development, American Indian health policy, environmental justice, and American Indian education. So we will now turn our attention to Ms. Dadgar. Thank you.
Thank you, Madam Co-Chair. Thank you very much. Greetings. My name is Maria Dadgar. I am an enrolled member in the Piscataway tribe of Accokeek, Maryland. When we heard Mr. Harold Phillips give the land acknowledgement, he named the Anacostia people, the Piscataway people, and the Pamunkey tribe, which they're more in Maryland, in Virginia. But that is my homeland. That's where I'm from. And I've been living and working in Arizona for 24 years. I started off working in Washington, D.C. at American University, created a national internship program for Native American college students, and got the attention of the Clinton administration and started putting students into the White House and other offices throughout Washington, D.C. And I met some folks from Phoenix, and they talked me into moving here about 24 years ago. So this is home now. I just want to talk a little bit about the Intertribal Council of Arizona. We are a tribal consortium of 21 of the 22 tribes here in Arizona. I report to the highest elected officials for the tribe, so that would be the tribal leader, president, chairman, governor, whatever their official title is. And so they are our board of directors. And as Laura said, they serve in so many of these leading roles for the work that we do at the Intertribal Council of Arizona. We have over 70 employees. You'll meet two of them over the next few days, Gwenda Gorman, as well as Kelly Vallow. They're both here, I believe. I'm not sure if they're here yet, but they will be. Oh, there's Kelly. They will be presenting, and they really are our frontline subject matter experts for so much of the work that we do. We operate over 60 federal grants, contracts, and cooperative agreements. Our three primary service areas are health, research, and environmental quality. The programs that we operate serve the BIA Western region. As Laura talked about earlier, tribes are divided into these regions, not only by the Indian Health Service, but also by the Bureau of Indian Affairs, the BIA. It just so happens that our two regions here in the Phoenix area align. So the Phoenix area Indian Health Service region includes working with all of the tribes in Arizona, Nevada, and Utah. So on a daily basis, I'm working with about 49 different tribes and tribal leaders, and they are all individual governments, as we've talked about when Laura explained about tribal sovereignty. The work that we do really is it ranges from working with babies and infants to elders. We have a WIC program where we service 10,000 families per month, 3,000 of which are babies. That's why I wake up every day and go to work, is because of the babies. They don't come to our building, but we garner the very large grants. And then through the programs that we get the grants from, we subcontract to our member tribes. Not only the tribes that are part of the Intertribal Council of Arizona, but the tribes that are within our region. We operate a tribal epidemiology center. We operate, we are a state agency for aging. We have 3,314 tribal seniors that we serve through our aging program. We have an annual operating budget of just over $30 million. Most of that is federal grants. We also have a few state contracts and a few very small private grants that allow us to do nonpartisan Native vote work. We get a lot of attention for the work that we do to help register our Native American population to vote and also to get everyone out to vote. We do not tell people who to vote for. But we get, yeah, people think we do, but we don't. Basically, the Intertribal Council of Arizona, we work to build tribally driven public health capacity. And we do that through service areas, including health surveillance, research, prevention, program evaluation, planning, and any kind of work that we can do to help tribal leaders make the best decisions on behalf of the health and well-being of their communities. So just not wanting to take up too much time because I know we have break coming up, but wanted to tell you a short story. I worked for another Native nonprofit in Mesa a few years ago. It was called the National Center for American Indian Economic Development. And by that time, when I went there, it was about 40 years old. I had the opportunity to meet the founder of that organization. He's Native American, Mr. David Lester. He's since passed away, but David Lester put the idea into the mind of President Jimmy Carter to create organizations and services on behalf of tribes. So the Administration for Native Americans, that was his brainchild. That's under the Health and Human Services Department. He also had the idea that there should be what we used to call a Native American desk at various federal agencies. And so he was quite a brilliant individual. I had the opportunity to meet and work with him, and he did become a mentor once I stopped being afraid of him because he was very intimidating. But I went to work at the organization that he had founded. The organization had been in existence for 40 years by the time I went to work there. And he came in one day just to visit, and he walked in, his tears just started rolling down his cheeks. And I went up to him and I said, "Are you okay?" And, and he said, "I'm fine. I'm just so happy and so proud." And I said, "Well, okay, yeah, we're happy to, have a job here." And he said, "I didn't know what I was doing 40 years ago when I created this organization. I just thought, we all need jobs. We need a job. I need a job. My cousin needs a job, And so he said, "I really didn't know what the outcome would be when I came up with that idea to create this organization and that all of you would be working here all these years." And so sometimes we're doing something right now today that we might feel a little burned out about, or we might why am I going to work again today? Is it for coffee or friendship or, whatever your reasons are? Sometimes we all do get a little burned out. But I always think about that conversation with David, and he turned around on me and he said, Maria, why did you come to work today? And I said, well, I came to work really, to see everybody, see my coworkers and get some coffee. I don't know. And he said, Maria, why did you come to work today? And I said, I need a paycheck. I came here to get paid. I guess I need a paycheck. And he said, Maria, why did you come to work today? And I said, I'm not sure, Mr. Lester. I'm not sure what you're looking for me to say. And he said, you came to work today to change the mindset of a people. And you came to work today to change the mindset from one of dependency to one of development, where we are empowered and we can do this on our own. And he said, so you came to work today to change the mindset of a people. And I said, got it. But then I ended up crying because it was such a beautiful way to look at your work and approaching your work. And I feel that here with all of you today. I'm honored to be here. Thank you so much for the time, and I appreciate it. I'm looking forward to the next couple of days. Thank you.
Thank you. No, we're running a little short on time, but I certainly want to not overlook the opportunity of those of us around your table. If you've got, a question, comment, or reaction, I know I need one. Actually, I was because my question is from all your perspective. I think what was new for me to learn is really the sophistication of the structure around ways in which tribal leaders have an ability to influence legislation and resources. And I think all of you sort of share various levels of ways in bodies, including yours, Maria. But my question really could have been about how PACHA might assist in terms of our role in providing recommendations and having influence with our colleagues around the work that they do to implement services. And so my question, I hope I can remember it appropriately, but do you feel as though the structures you have, the systems you have, are enough or sufficient to influence and gain and gather what you need? Laura, in particular, you said your sort of structured advisory board at the secretary level, where I immediately went to. So for HIV is only the only sort of White House in which you have an ability to programs and policy. And so, sorry about that. He's talking to the mic. So really it's about, with all that is there, what more would you, from your own perspective, say might be necessary, or would you recommend that happens in order to affect change or actions at the federal level?
So I would say one of the main ways that PACHA could support tribal nations, I do think obviously funding is always an issue. Sure. And there is a shortfall in that area. But one thing that did happen during COVID is tribes were able to get funds transferred, interagency agreements between an agency like CDC or SAMHSA. They actually transferred funds to IHS, and IHS was able to put those in a tribe's compact or contract. And that was a very expedited, direct way of getting funds to tribal nations. So that is one way possibly that tribes could get funds. And of course, not all tribes have compacts or contracts, but that is one opportunity. I know tribes in our areas, in the Northwest, really like that mechanism because it really supports tribal self-governance and self-determination. Also, like, for example, CDC has a tribal advisory committee. CDC hasn't significantly funded tribal communities in a really long time. So, being able to get something on that agenda, even for needs related to that, making sure that HIV is being addressed across, all of the different agencies, and making sure that information is collected. It's definitely, there are so many health disparities our tribes are dealing with. heart disease, long COVID right now for many communities, diabetes, that HIV, it's hard to get it to the top with so many. So I don't know if you.
Sure. Just to jump in and add to what Laura said, Madam Chair, our organization is a formal body of elected officials. And so we do have regular board meetings where we consider passing resolutions. And so I don't think that we've ever been approached, by PACHA to, possibly pass a resolution in support of your work or pass a resolution where we're partnering.
Yeah.
We did form a political advocacy arm about 6 years ago. It is called the Intertribal Association versus the Intertribal Council. The Intertribal Association of Arizona, ITAA. Same tribal leaders, a different set of executive officers, but we do go to DC once per year to advocate. Our tribal leaders are our best advocates. And we prepare the policy statements for them, and they go on the Hill and they shake hands. And just being in DC, the synergy there is amazing. But maybe we could meet once we're, in DC. We go every April for a whole entire week. And so that's, I think, would be something that would invite more collaboration, more opportunity. Thank you.
Vincent.
So just want to say thank you very much for the presentations. I think it was fantastic and sorely needed. I'm really happy that we're focusing on the community that we're focusing on at this meeting. I do have a question. Sorry, Mike should be helping me, but how's that, Carolyn? So I do have a question, and I did hear a response to this, and it builds on Marlene's question, but I've been astounded for a number of years at many of the meetings that I attend where there is reference to Indian Health Service and this sort of consistent and pervasive underfunding of services. And I guess I want to push a little bit, and I don't want to put the panel on the spot, but I do feel like I would like to understand that more, because I'm fearful that we'll have this session and that the specific ways that we can try to improve the sort of resources to do the work that will evade us. And so I don't know, Laura, I'm sort of looking at you as an attorney, but the panel in its entirety, what are we missing here? Because I've been hearing this and it's been pretty pronounced. It's not even subtle. It's like very blatant.
That's a good question. I know our tribal leaders would say it's a failure of the federal government to honor trust and treaty obligations. That's really what it comes down to at the end of the day. And in the tribal recommendations that the National Indian Health Board, it publishes the document every year where tribes make the request to IHS for funding. And in that document, they clearly highlight, what the needs are. And, as you know, the president often proposes a significant increase for the Indian Health Service, but then when it gets to Congress, it doesn't, it's not as much as was proposed. So if those presidential recommendations were to be approved by Congress, and move forward, we would have much more funding. So, I mean, at the end of the day, that's what I know our tribal leaders would say.
Appreciate that. We will take our last comment.
Hello, thank you. My name is Kelly. I'm with the Intertribal Council of Arizona. I just kind of wanted to make a comment as well as how PACHA could assist. I know Laura talked about federal trust responsibilities. It's also understanding what those responsibilities are in creating programs or grant funding or any type of services that are directed to Indigenous or Native American communities, bands, villages, and or nations, but making sure that those communities are at the table involved in creating and developing those programs that are best beneficial and effective to that community. I see a lot of times, a lot of these programs are created, and then after the tribal leaders are then asked to come to the table and say, this is what we created, what do you think? That is not federal trust responsibilities. Federal trust responsibilities would be including those tribal nations into that planning, as well as what we've talked with our partners, as well as not reinventing the wheel in regards to programs that are already out there, programs that are already utilized by those tribal nations for those tribal nations, and seeing what and how that can be tailored on a more universal level for Native American communities. Thank you.
Thank you. Excellent comment there. And I do think, important reminders that some of these basics in a lot of the work that we've done for many years around service delivery, those basic principles remain the same, and ensuring there is real influence and representation from the beginning, including planning phases of services and programs. So I appreciate that comment too. With that said, we now are poised for a break. I do think we can still take our full 10 minutes by my watch. That puts us back at a start time right near 11:20. I know it's 9 minutes, so right near 11:20 we will resume. Thank you.
Produced by the U.S. Department of Health and Human Services.